survey. With that, it's now my pleasure to introduce Cassandra Zieminski. Cassie is the Patient Safety Specialist at Tufts Medical Center, where she oversees the Adverse Event Reporting and Investigation System. Before joining Tufts Medical Center, Cassie was a Human Factors Engineering contractor at the U.S. Department of Veterans Affairs National Center for Patient Safety. She assisted the facilitation of healthcare failure mode and effects analysis in the VA medical centers and coordinated the development of a web-based application for VA proactive risk assessments. Cassie's earned a Master of Public Health from Boston University School of Public Health and a Bachelor of Science in Biomedical Engineering from Western New England University. Cassie, the floor is yours.
Thank you very much. Hi, everyone. Today we'll be discussing a proactive risk assessment methodology called Failure Modes and Effects Analysis. Here is the webinar agenda in front of you. We'll walk through the purpose of proactive risk assessments, introduce FMEA and describe its utility in the healthcare setting, and then we'll learn the FMEA process steps while following along with a simple example. You can really summarize the term proactive risk assessment with two questions. We first ask, what could go wrong with this process or product? And then, once we determine what could go wrong, we ask, what can we do to prevent this from going wrong or prevent this from causing harm? In a proactive risk assessment, we thoughtfully examine a process and you could say, put it under a magnifying glass to identify any vulnerabilities in the process. Then we make corrections. You know, the beauty of this is that nothing had to go wrong first. No one was harmed beforehand. When you think about it, we're all probably conducting some form of proactive risk assessment in our everyday lives. Take, for example, your process for getting ready for work. You wake up, take a shower, brush your teeth, get dressed, fix your hair, eat some breakfast, pack lunch, and then get on your way. The goal is to get to work, put together and on time, but we all know that sometimes things don't go exactly as we had planned. So what do? We do our best to implement fail-proof elements into our routines. Let's examine the first step, waking up, as an example. First, we break that step into smaller pieces so that we better understand it. We've got steps A through E. We set an alarm, we go to sleep, the alarm goes off, we turn off the alarm, and then we get up. So let's ask, what could go wrong with this step? The obvious answer is that I don't wake up. This failure could completely derail my morning, so I'll examine the reasons why I might not wake up. I could have forgotten to set my alarm at night, I slept through the alarm, or I set my alarm on my phone and my phone battery might die overnight. So finally, now that I've examined that potential failure and its causes, I'm going to do something to ensure that I don't have a morning where I don't wake up on time. I'm going to set a recurring alarm so that I set it and it just goes off every day when I need it to. I'll set my alarm on really loud so it wakes me up, I can't sleep through it. And I'll make sure I charge my phone overnight so that it won't die. So I conducted this risk assessment and made corrections or reinforcements to that process of getting up in the morning proactively before I ever had a morning when I accidentally didn't wake up in time for work. We conduct proactive risk assessments also in healthcare, and that's so that we can prevent accidents and potentially catastrophic events before they have a chance to occur. The Joint Commission says that at least every 18 months, the hospital has to select at least one high-risk process and conduct a proactive risk assessment. The Joint Commission also says that not only do we have to conduct that risk assessment, but we need to use it for improvement. They say that the hospital must analyze and use the results of proactive risk assessments in order to improve safety and reduce the risk of medical errors. So how does the Joint Commission define proactive risk assessment? Let's break down this Joint Commission definition for proactive risk assessment. A proactive risk assessment examines a process in detail, including sequencing of events. We're thinking of process mapping here. Actual and potential risks and failure or points of vulnerability. So that's what could go wrong. And that prioritizes through a logical process areas for improvement. One such logical process that can be used to prioritize areas for improvement is the methodology known as failure modes and effects analysis. So let's define FMEA. It's failure modes and effects analysis. It's a method for identifying ways that a process might fail, the failure modes. It's also a method for considering why the process would fail, the causes, determining the impact of those failures, the effects, and prioritizing which potential failure modes could be addressed first or using the most resources, the actions. FMEA was first developed as an engineering tool. Engineers might use FMEA to detect and prevent errors with the products that they're engineering. So earlier on, this is an example, earlier on in the development process, they analyzed the failure modes of a product design to determine which failure modes they could eliminate or mitigate as they further develop their product. For example, let's say a certain type of point-of-care diagnostic device needs to operate in the field in different climates. If the product isn't designed with this in mind, the product could malfunction at hotter and colder extreme temperatures. Engineers would detect this failure mode through the process of FMEA, and as a result, they would know to incorporate this knowledge into their design, and they would select certain materials that they know could withstand extreme temperatures. So we can use the same methods in healthcare settings to analyze and mitigate or even eliminate the risks associated with certain care processes. In healthcare, FMEA helps us to predict failures and eliminate avoidable errors and mitigate the consequences of any unavoidable errors. FMEA doesn't require an event or close call to happen first, and that's why it's so valuable in healthcare. In fact, unlike the RCA, the root cause analysis, which is used for analyzing a specific incident, FMEA is used for analyzing a system or process, not an incident. Remember, RCA is a retrospective analysis, and FMEA can be done proactively. FMEA also offers a framework for quantifying and ranking risks so that we can prioritize the improvements that we want to make. Resources are limited, so this is really valuable. We can tackle the areas of greatest risk first. Finally, FMEA is aimed at creating fault-tolerant, reliable systems and processes. We try to prevent errors from occurring. If we determine we can't completely prevent an error from occurring, we reduce the likelihood that the error will occur, and we try to reduce the consequences or harm brought to a patient or to an employee if that failure mode does occur. Here are the steps of the failure modes and effects analysis. We select a process to analyze, assemble a team, describe the process graphically, run a hazard analysis, and then we think through the actions and how we'll measure those actions. We'll work through this process on the following slides alongside an example. So the first step in FMEA is selecting a process to analyze. If you recall the Joint Commission element of performance we looked at earlier, it says that the hospital must select a high-risk process to analyze every 18 months. The first bullet point on this slide uses that Joint Commission definition of a high-risk process or procedure. It's a process or procedure that has a significant potential for affecting the safety of a patient or an individual served, like an employee or a visitor. Processes with greater potential to cause harm might be processes that are complex. For example, they involve multiple departments, or they're non-standardized processes, or they're very people-dependent. Humans are making decisions and interacting very often during the process. Those are things we would consider high risk. Here are a couple of examples of processes and systems that you might consider analyzing with a failure mode and effects analysis. You see on this list examples of existing processes like getting critical lab results or giving blood transfusions. You also see an example of a new system to be implemented. That's the first bullet point in this list. Implementing a new barcode medication administration system. Before a system's implemented, that's a great opportunity to conduct a proactive risk assessment using FMEA because it can help the hospital to identify all of the potential failures and risks associated with that new system, and so that they can design their processes or the trainings that they will give around this new system using the results of their analysis. So just keep in mind it can be used for new processes or those that are already in place. So once we select a process, the next step of FMEA is assembling the team. FMEA is a team-based method. It relies on people with different knowledge and perspectives coming together to brainstorm. It would be very challenging for one person alone to come up with a comprehensive list of failure modes and causes because he or she has limited knowledge and expertise. Together, when we assemble a team, the multidisciplinary group of about 6 to 10 people for FMEA can really effectively brainstorm. So the team should include subject matter experts. Those are people with clinical expertise. So you would want to have, if you've got a doctor, you want to have a nurse too. If you have a nurse, you want to have a doctor too. You also need to have representation from all of the involved areas in the process. A team leader should be present too, and that should be someone with some decision-making power in the hospital. An interesting addition to the team is an outsider, someone who is a completely unbiased party. They're uninvolved in the process, but they have something valuable, and those are fresh eyes to offer to the analysis. The team will also include a method expert or the FMEA facilitator and a recorder, someone who takes the notes and keeps everyone on track and all of the information organized throughout. The third step of FMEA is to graphically describe the process. This means that you'll create a visual representation of the process using a process flow diagram or process map. Remember to define the beginning and the end of the process and keep the scope manageable. You'll be able to do the best analysis when you keep the scope clear and well-defined. Otherwise, it might be challenging to get your arms around the process. Also, just one piece of advice is to number the steps. That helps to keep everyone organized and on the same page throughout the analysis. So let's start our example. Here we'll be looking at a laboratory testing process, just a very, very basic process on the slide right now. We're looking at the essential steps in that process. The lab test is ordered, blood is drawn, the sample is transported and then analyzed, and then the results are reported. Notice that we've numbered the steps here to keep ourselves on track. Next, since there's some complexity within these essential steps, we'll spell out the sub-steps for each of these steps, 1 through 5. For the sake of our example today, we're going to be using a small section of this lab testing process to base our example off of. Step 2, blood is drawn, includes 4 sub-steps. We identify the patient, gather supplies, draw blood, label the sample. We've lettered these sub-steps A, B, C, and D. Now we'll visually map out the sub-steps of step 2. Blood is drawn, taking special care to maintain this numbering and lettering system throughout. So here it is. We've mapped out the sub-steps of the blood is drawn step in our process. And so for the sake of our example, this is the process we'll be analyzing using FMEA today. So this part, FMEA, describes the process graphically, is now complete, and we'll move into our hazard analysis. So step 4, the FMEA, is to conduct the hazard analysis. And the first part of that is brainstorming failure modes. This is where we ask what could go wrong. And we list out the failure modes in each step of the process that we just mapped out. So here's that sub-process again that we're analyzing. For each step, we list potential ways the step could go wrong. These are the failure modes. So for the sub-step, identify the patient, a failure is that the patient identification isn't done at all. For the sub-step gathering supplies, the failure mode is that the sample tubes aren't available or the wrong tube has been selected. For the sub-step draw blood, patient veins aren't easy to reach, could be a potential failure mode. And then on the label sample sub-step, failure modes could include incorrect information on the label or the sample's not labeled at all. So notice that the failure modes are numbered. So we're still maintaining our numbering and lettering system. Okay, so now that we've determined the failure modes for each step, we are going to list the possible effects, causes, and controls for each of those unique failure modes. Before we jump back into our example, let's define effect, cause, and control. Okay. The effect is the failure of the failure mode is how the failure mode will impact the patient or how it will impact the process itself or any other individuals involved. The cause of the failure mode is the underlying reason why that failure mode occurred. And then controls. Controls are things that are in place to prevent the failure mode from occurring. I can give you a couple of examples. Control might be an alert or a warning from an electronic system that's automatically sent to a user. Or it could be a design feature on a piece of equipment that makes failure near impossible, like intentionally incompatible tube connectors. A control could also be visual cues that are detectable by the human eye, so we color code for this reason to prevent people from choosing the wrong things. Or a control could also be a purposefully designed process redundancy, like a second individual to perform a second check on a certain order. So here we are, brainstorming failure modes along with our effects, causes, and controls in a tabular form. I find it easiest from this point forward to organize the failure modes, effects, causes, and controls in a table. In this table, you can see that we've listed the 4 sub-steps, A through D, in step 2, draw blood, in the leftmost column. So we have our steps A, B, C, D listed down that column. Then, in the second column, we've listed the failure modes that we determined for each of those sub-steps. And we'll use the columns to the right of that to list out our effects, causes, and controls. So let's work through the first row. Step 2A is patient identification. The failure mode is that patient identification is not formed. What might be the effect of that on the patient? It's that perhaps the wrong person's blood is drawn, which would lead to inaccurate results posting to the intended patient's chart, and then treatment decisions could be made based off of the wrong information. So what could cause this error? It's likely that the cause of this error would be centered around human factors. It might be that the person drawing blood was overwhelmed or fatigued and therefore susceptible to distraction and accidents. It might also be a function of their training. Now, what is currently in place to prevent this error from occurring? What are the controls here? At the moment, the only control in place for this example medical center is training for the people who are doing blood draws. So now we've got the table filled out. Your team will systematically analyze each of the failure modes you listed earlier until you have listed out all of the effects, causes, and controls for each failure mode. I hope this helps you to see the value in using a tabular way of visualizing this information. It really helps to keep organized and to keep everyone on track. Okay, so we're still moving through our hazard analysis. Remember, so far in our hazard analysis, we've used our team's expertise and brainstorming power to list out the failure modes, effects, causes, and controls. This was the qualitative component of the hazard analysis. Now, we will be moving into the quantitative part of the hazard analysis, or the risk quantification and prioritization part. We're going to assign scores for each failure mode in terms of 3 factors. Severity. How significantly will the failure affect the patient or process? Probability. How often might the failure mode occur? And then detectability. How likely is the failure mode to be detected before reaching the patient or before affecting the process? On the next few slides, I'll show you the reference scale that we'll use in our example today. Please feel free to use these scales in your own work, but be mindful that there are other scales you could use. Some have 1 through 10 numbers with different levels of severity, probability, and detectability listed out. Others are 1, 3, 5, 7 scales. Just remember, you can customize the scale so that it works best for your organization. It's just very important that you do follow a reference scale. So the severity scale, we've got a 1 through 5 scoring system. This is covering severity in terms of impact on the patient and also impact on the process. 1 here is the lowest severity, and then we work our way up to a 5, which is the highest severity. Then the reference scale for probability and detectability look quite similar, 1 through 5. So for probability, 1 represents that this is the lowest likelihood, and 5 would be the highest likelihood. It's something that's almost inevitable. Finally, detectability. 1 would be the highest detectability. That means it's almost always detected immediately. And 5 is the lowest detectability. It's impossible to detect something, or this failure mode. So we use our reference scales to assign scores to each failure mode in terms of severity, probability, and detectability. And then once we obtain each of those values, we multiply them out and calculate a risk score for that failure mode. It's called the risk priority number, or RPN. RPNs help us to identify which failure modes are the most dangerous. For failure modes with high RPNs, we would consider them to be more serious, so we prioritize them and address them with more effort and resources. For failure modes with lower RPNs, we might accept them as just potential low-risk errors, or we could address them later on, or we might address them with less effort and less resources, just because we've deemed them to be lower risk. Okay, so here we're moving back into our example. For each of the failure modes that we thought of before, we've assigned a severity, probability, and detectability score. Then we multiplied those scores together, and we calculated a risk priority number for each failure mode. This concludes our hazard analysis. We've done the qualitative part of it, and then we finished up our quantitative part of it. We've determined a risk priority number for each. The final step of the FMEA is using the analysis to determine actions and to decide how we'll measure and evaluate those actions. We want to eliminate risk if possible. That means we want to make our processes fail-proof. But if failure can't be completely eliminated, we want to eliminate or implement actions to control the failure mode or minimize the risk of that failure mode. So we want to make our processes fault-tolerant. The ultimate goal is to implement actions that will reduce the risk priority number of each failure mode. That is, reduce the severity of the failure, reduce the probability that the failure will occur, and increase the detectability of that failure. We prioritize where we will focus our resources and efforts by focusing on the riskiest areas first. This means that we rank the failure modes by their risk priority numbers, by their RPNs. So here I've just used a bar chart to visually represent which of our failure modes from our lab testing example we deemed to carry the greatest risk of harm to the patient. These are the failure modes that we'll focus our actions on in this example. So our actions are now listed in the table. These are the improvements that we want to make in order to reduce the risk associated with each of the riskiest failure modes. Notice we've got the 3 riskiest failure modes as determined in our hazard analysis listed in this table. And at this stage, we also need to identify who will be accountable for implementing the actions and what the goals and date frames are. So for example, one of our failure modes was that the tube label had incorrect information on it. That would be this one. We said that printing equipment malfunctions and inefficiencies could cause this to occur. So we decided that one of our actions to address this would be to use handheld label printers at the point of care to reduce the probability of putting the wrong label on the wrong tube. We've determined who will be responsible for ensuring this action is done, and we also wrote in a goal that we will purchase and use point of care label printers on 2 units by July 1st of this year. Okay. So here are a few tips as you implement the actions. Compile the analysis into a single document that can be shared with higher level management. You'll need their support and approval before moving forward and providing them with documentation. Before moving forward, you will need the approval of higher level management, and providing them documentation of the thorough analysis that your team conducted using FMEA will be the perfect way to make your case. You'll also need to ensure that the actions are followed up on. So my recommendation is to plan and put in your calendar those follow-up meetings that you would need based on the actions and the goals and the time frames in advance. Finally, debrief after the actions have been implemented. You should reconsider the risk priority numbers of the failure modes you've addressed. So you would want to, after the actions are implemented, ask how much did those actions reduce the risk associated with each failure mode? Was the failure mode completely eliminated? If so, that would be excellent. Also, you'd want to consider whether the actions may have generated any new potential failure modes. One of the most common instances of this would be the implementation of new technology solutions. So those in particular may generate new failure modes. So be mindful of that. And remember that proactive risk assessment does not end when the FMEA meeting ends or once the actions are implemented. Always be asking what could go wrong. It's not pessimistic, it's just proactive. So before we conclude, I want to talk through a few potential logistical challenges you might face while conducting a FMEA. So think about the example we looked at today. We analyzed failure modes for sub-steps of a larger process, and even that can be quite involved and time-consuming. If we had looked at all of the steps involved in the lab testing process, or if we analyzed a completely different and even more complex process, the FMEA would take some time if done thoughtfully. The group will repeatedly determine failure modes, list causes, assign RPNs, and so on. So my advice to you is that you ensure a good amount of time is blocked off for the FMEA. All team members should be available for that half-day or whole-day session in order to complete the analysis. Also, you can use the FMEA facilitator as a mediator. For example, if the group is torn on assigning a severity or a probability score for a certain failure mode, utilize the FMEA facilitator, the method expert, as a tiebreaker if you need them to, so that your group can efficiently move on and continue to assign more scores for all of the failure modes. Also, one final challenge that I'm recognizing here is to ensure that your meeting area has some wall space or a whiteboard. It's best to facilitate this analysis when everyone is able to visualize, so that everyone's on the same page. So writing things out on a board or easel paper will help the group to stay focused and organized. The recorder can then take photos of the whiteboard or save the easel paper and transcribe the analysis into a final document later on. So here are a few summary points I'd just like to make sure you've grasped today. Remember that FMEA stands for Failure Modes and Effects Analysis. And I won't read through all of these, but just keep in mind that you should think of FMEA as a continuous improvement tool. We should always be asking how a process could fail and what we can do to prevent that failure, even after the FMEA is done. So with that, I'd like to open the floor to the participants and ask if anyone has any questions. I'll watch the Q&A box if anyone would like to type in their question, but please feel free to unmute yourself using *7 on your phone to ask your question if you have one.
Cassie?
Yes, hi.
Can you hear me? Hi. Massachusetts, Neshoba Valley Medical Center. So talk a little bit, if you would, on goals. So it looks like when you're starting the process, you shouldn't really have a defined goal, because once you do your hazard analysis, that for each step and sub-step, the goals could be different. Is that correct?
So let me make sure I understand your question. So you're asking if it would be not the best idea to set your goals before you enter the room and conduct your hazard analysis?
Right.
Right. I would agree. You don't, you want to make sure that the whole group is in the room. You're working through very systematically, planning out or writing out what those failure modes are, analyzing it in terms of the causes, the effects, and the controls. And then based on all of that information, with no preconceived goals, once everyone is informed and on the same page and everything's been poked holes into all of the failure modes, at that point in time, thinking of the actions to directly affect those specific failure modes and setting goals on those actions would be the best way to go about this.
Okay. Yeah, that's what it looks like to me, because your goals, depending on the step here, whatever step you're in, would certainly be different. There could be, though, could there be one overriding goal, such as, well, one of the ones we've embarked on is a certain area for the medication reconciliation process. So the overall goal is basically we don't want any more incident reports, but obviously, depending on the hazard analysis and what step you're in, your specific goals, maybe goals and objectives is a better way to work with the group. The overriding goal is for medication reconciliation not to be broken, or however it can be written, but then your objectives would be specific to your steps in your hazard analysis.
I like the way that you're organizing that mentally. I think that that is a great way to look at it. You're right. You can have an overarching theme or an initiative, and then you're using very specific actions and measures to multiple very specific actions and measures to achieve that initiative.
Okay, great.
I would agree.
All right, good. Thank you.
Thank you so much for your questions.
Hi, Cassie. I have a question.
Hi.
Who is it that really determines that an FMEA is warranted? Is that something that typically, the quality group is saying, well, how does it come about, really, in your experience?
That's a good question. So here at Tufts, it's actually kind of a decentralized decision-making process. And it would be up to the specific functional areas or the units themselves to think about what analysis they might need. They would decide what would need to be, what proactive risk assessment might need to be done. So, I mean, for example, we have our IT group and pharmacy. They are very engaged with conducting proactive risk assessments, and they are the ones who decide to come up with that. So that's how it's worked here. It's not necessarily the hospital will set like this is the one proactive risk assessment that we will conduct within this 18-month window. It's a little bit more decentralized at Tufts here.
And a follow-up to that would be how do you, in quality, as sort of the gatekeepers, if you will, to Joint Commission documentation and data, how do you ensure that you're either involved or that you receive that feedback that the FMEA has been completed?
So that's another great question. And the answer is that we want to have the action plan and the results, the progress in between, reported up through the channels, up to the quality committees as appropriate. So, for example, we might have a medication or pharmacy-related plan come out of a proactive risk assessment in FMEA, and that would get reported up to the Medication Safety Committee, and ultimately it might go up to a greater quality board, just so that everyone is informed of the great work that was done.
Thank you.
Thank you so much. I'm seeing a question come over the message board here. I'm curious about the team assembly, in particular, the choice of the outsider. Would this be a role a patient care advisory board member could assume? Are there other examples? That is an excellent question. And the answer is a patient care advisory board member would be a great participant in that as a member of the team because they are engaged with the care but not necessarily a subject matter expert or an area expert at all. So that would be another great example. Also, I mean, someone who's just from a different area, from a different, like either geographic area within the hospital or a different department, they could still provide fresh eyes if they were available and willing and ready to participate in the FMEA. Then they would just be another great example of an outsider. So we've got another question coming in, typed up. The question is, can you verify again that the FMEA controls column identifies the items and processes that are currently in place, not what should be in place? Excellent question. I'm happy to clarify. So yes, when you are thinking about your process as it is now, or if it's a new process as before any other design controls are implemented, just the out-of-the-box system for a new process. You are only listing in the controls column any checks that are available at this time, any of those processes that exist currently, and not things that could exist. Those would be some actions that you'd like to implement, usually to improve the detectability of that failure mode. So if there are no more questions, I'd like to just thank everyone for your time. This was wonderful.
Yes.
Oh,
thank you, Cassie. Thank you so much for taking the time to share with all of us today your expertise in the use of failure modes and effects analysis.